Welcome to PCR eCourse 2020. It's a great pleasure for me to moderate this very exciting session on the innovative solution to treat diabetic patients. For that, I have my good friends, Luca Testa from Italy and Marie-Claude Morice from France, who are very well-known interventionalists and very active in the field of research to comment and to give presentations on the subject. I would like also to thank Concept Medical to sponsor this session. A quick slide to show you the flow and the program. First, I'm going to introduce the theme as a new solution and a new technical solution to treat diabetic patients with a very exciting new stent. And then I give the word to Luca Testa, who's going to discuss with you imaging and clinical insights of Abizaid technology. That's the technology that we're going to be talking about. And finally, Marie-Claude Morice will discuss with us the Ability Global Diabetes Study, which is certainly the largest randomized trial to treat diabetic patients. With that, I would like to start my presentation with the following title, which is the innovative solution to treat diabetic patients. And these are my conflicts. My first slide will talk about the magnitude of the problem. We know that diabetes is more and more frequent in our daily practice. This is data from Mount Sinai, which is a very high volume single center with interventional cardiology, and this slide shows you that almost half of the patients, 46% of the patients that are treated with PCI in Mount Sinai will have diabetes. So again, it's more and more frequent to have patients with diabetes to be revascularized. My next slide will show that the combination of coronary disease with diabetes is very lethal, both for global mortality, but also for cardiovascular mortality. In blue is the combination of diabetes and cardiovascular disease. And when we compare, for instance, with non-diabetics in green, you see that the mortality can go 10 times higher when you only have patients with no diabetes and coronary disease. So why diabetes is a major problem? First of all, we have more diffuse disease. We have more increased necrotic core volume in the atherosclerosis and plaques. We also have increased inflammatory infiltrate and certainly more calcification. So to treat these patients with more diffuse disease is certainly a bigger challenge. Particularly for intervention, for PCI, what we generally see in the diabetic population are patients that will have more delayed endothelialization and certainly more increased inflammatory response. With that, we generally see a little bit more thrombosis and certainly more restenosis in the patients that we treat with diabetes. Now you can argue that with the more contemporary era with next generation DS, such as Science, in this trial, we have close to 4,000 patients from the Spirit 4 when we compare Science versus Taxus. Again, you might think that newer stents will have the solution for diabetes, but certainly it's not the case. You see that when we compare Science versus Taxus, first generation, particularly with the diabetic population, when they are treated with insulin, you still see very high rates of MACE. On the other hand, in the non-diabetic population, you see that when second generation is used, you have half of the events as with first generation Taxus. So we still don't have a perfect solution to treat diabetes, even with the next generation devices. That's why I think it's important that we struggle to come up with better solutions to treat diabetic patients percutaneously. And Abinumulus is certainly has a very good potential to treat these patients. So a few minutes to explain the technology. Abinumulus is a stent that has abdominal coating, which certainly make more efficacious to transfer drug to the vessel wall and to facilitate the monodirection. Also, it has this fusion coating, which not only coats the struts, but also parts of the balloon. So you have a more homogeneous distribution of drug. And again, the surface of the stent and the balloon that will touch the vessel wall will certainly inhibit neointimal formation more potently than a stent that only delivers drugs to the struts. So that's a very fascinating concept that might help us in the future. Additional features of this device includes more drugs at the edge. So the company was able to additionally put more coating and drug at the edges of the stent when you generally see, particularly in the diabetic population, more edge restenosis because you have more diffuse disease, but also this biodegradable film that can protect the whole device to release drug in the more controlled way. So the so-called distal embolization of particles can be avoided when adding this film. So those are very interesting features that can make this device a great solution for diabetics. Also, in terms of the platform, you see that Abinumulus has one of the thinnest strut in the market. So to be in the range of 70 micro is something that we also appreciate. So what about preclinical work? So it's important because before we go aggressive with clinical studies that we have some strong evidence that this device is safe and efficacious. So this is the platform again that was tested preclinically. That's the distribution of the drug through the stents, and again on the top of the balloon. This is a sim picture that shows that how homogeneous is distribution of the polymer and the drug throughout the stent segment, including the balloon that is exposed to the vessel wall. The preclinical work, to make a long story short, showed us a nearly complete endothelialization at the 7th day, as this same picture shows. Also showed good inhibition of neointimal proliferation at 28 and 90 days. Low injury scores with moderate to low inflammation, and the absence of thrombus or any adverse observation in these histology pictures. With that, I think we all felt very safe to move ahead with the clinical work, and this is going to be the task of Luca Testa to describe in details. I'm just going to lay out some important studies that the company and some investigators had the initiative to put together. After this first-in-man study with 40 patients that Samir Dani performed in India, immediately we started a larger study, mostly included in multi-center in India, 2,500 patients. Immediately after that, Luca Testa is leading a very large registry of 5,000 patients in multi-center manner in Europe. And moving ahead with randomized trials, we see the ability imaging sub-study with a lot of OCT to understand the comparison with science with Abinumulus in terms of neointimal formation and toxicity to the vessel wall. But the most expected trial is certainly Ability Diabetes randomized trial with 3,000 patients that Marie-Claude will describe in details. And also an important study with 1,500 patients, particularly for unstable patients, ACS patients. So very strong clinical program to prove that this technology can really be one of the best solutions for diabetic patients. With that, I thank you for your attention. And if you can stop for a few minutes, I'll be happy to take some questions.
Alex, I would be happy to ask you a question. Why did we fail us interventionalists with diabetic patients?
Marie-Claude, I don't think we failed in all kinds of diabetic patients. I think we do have diabetic patients with perhaps oral medication, not so much diffuse disease, more focal stenosis that we can treat with stents in a very safe and predictable way. But you're right, when you have multivessel disease patients with a lot of diffuse disease, it's a little bit harder for us to have a more predictable, sustained result at long term. That's why our friends surgeons will probably win this battle, right? Because when they revascularize these patients completely with a distal anastomosis, and the progression of disease is certainly will guarantee a lot better long-term result. But I believe that with solutions like we are discussing today, that will certainly decrease the rates of restenosis. Edge restenosis, very common in diabetic population. And again, a more sustained inhibition of nail intimal formation with a combination of stent and balloon coating, we might be a little bit more aggressive in percutaneous solutions.
Thank you.
So I think if there is no further question, it's my pleasure to introduce Luca Testa, that will cover some of these exciting clinical programs that we mentioned before in a little bit more details. Luca.
Hello, everybody, and thanks for this kind invitation to talk about the experience in, well, let's say clinical data, but also some experience coming from the imaging insights. And I would like to, well, these are my potential conflict of interest, and I would like to start talking about what has been published already and is freely available in the literature. I mean, the first experience is coming from the Enable-E registry that has as objective to evaluate the safety and efficacy of the Abluminous Death Plus in an all-comers population with minimal exclusion criteria. This was really a first experience where the stent has been applied to a real all-comers population without exclusion criteria, I would say. The study design was simple, multi-center prospective, and has been performed in 31 centers in India. As a study endpoints, you will see the primary endpoint is actually the classical MACE as a composite of cardiac death, target vessel MI, target lesion or vessel revascularization at 1 year follow-up, and several others secondary endpoints. And as you can see here, the overall populations included 2,500 patients. But what is really important for us is the fact that in this all-comers population, more than 800 patients were diabetic, as you can see in the left side of the screen. In particular, there were more than 700 non-insulin dependent diabetic. And these are results. As you can see, they didn't notice any significant difference across the population, regardless the presence or not of diabetes. So in other words, it seemed like that stent was able to provide the same level of performance regardless the presence of this strong risk factor. So that was actually the idea, to start to go even deeper in this technology. And I'm proud and happy to say that we've been able to design this worldwide registry, the Dedicate. And this Dedicate is actually targeting 5,000 patients worldwide, with a primary endpoint, which is slightly more modern than the classical MACE, because a target lesion failure, such as a composite of cardiac death, target vessel MI, and clinically indicated target lesion revascularization within 12 months, and a full list of secondary endpoints. And I'm also very happy to say that now we are still opening other centers worldwide, but we are in the range of more than 800 patients and more than 20 centers already activated. So going ahead, in terms of the beginning of this strong clinical program, I must mention the Ability randomized control trials already introduced by Alex. This is a randomized clinical trial comparing the Abluminous versus the everolimus-eluting drug-eluting stent. It was an investigator-initiated pilot study where a very specific endpoint, indeed the objective, was to compare geographic and clinical performance of the Abluminous Death Plus versus everolimus-eluting drug-eluting stent in patients with diabetes. But besides being a multi-center, single-blind, randomized trial, the aim was actually to compare on an imaging level the performance of this new drug-eluting stent according to one of the blockbusters of the DES nowadays available, the everolimus family. So, in other words, the primary endpoint was the in-stent neointimal volume at 9-month follow-up, measured with OCT following PCI. And again, a full list of secondary endpoints. But I would like to also show you what is the status of the trial. So we are very close to the end of the enrollment, and I'm happy to say that we are having a very good performance. But it's also a pleasure now to show you some imaging, because it's really important to understand where is the strong rationale for, let's say, to proceed with a strong clinical trial and the program. So it's the case of male, a gentleman, 50 years old, type 2 diabetes, hypertension, dyslipidemia, and family history of coronary disease. In 2018, he has been tested and found positive ECG stress test. The echocardiogram was normal, ejection fraction was normal as well. And these are some pictures. So as you can see, there is mid and distal RCA critical stenosis, definitely deemed for and suitable for PCI. This is also the left system. As you can see, there are critical stenosis in the LAD, in first diagonal and LCX, which is a typical aspect for diabetic patients who rarely present with just a single vessel disease, but more often with a multivessel disease. So this patient has been enrolled and treated with the implantation of a Bluminous DES Plus with a 3.0 by 28, post-dilated with a 3.0, and then just a POBA for the diagonal. That was relatively straightforward procedure. That's the final result, pretty acceptable. So this patient has been enrolled in the Ability randomized controlled trial pilot study. And of course, before and the enrollment has been actually staged with for a complete revascularization done on the right coronary. And then this is the planned OCT for the LAD. The patient was totally asymptomatic, but I'm very happy to show you and to let it go the OCT that we did for this LAD. I would like to draw your attention to the fact that this OCT is showing a very bad and diffuse disease throughout the length of the LAD. But what is really, it was surprising for me, I have to say, that if you look at the edge of the stent, this is the distal one, the edge of the stent was absolutely nice, totally covered, but without any hint of neointimal hyperplasia exceeding the level of restenosis. The stent was fully covered, and we can say that even the proximal edge was absolutely fine, as you can see right now, despite, I have to say, some kind of progression of the disease in other segment of the same artery. So this is just a picture to show the endothelialization of the full endothelialization of the stent, which is truly important for what Alex just said. This is the MLA that we found. And in the top left of the slide, you may see some calculations that we've seen. So the strut coverage, I would like to start from that. Strut coverage was 100%. The max neointimal thickness was 0.5, far away from any possible threshold from critical restenosis. But also the neointimal area at the narrowest segment was 1.91. So in other words, a very, very good result. This is case number 2. Another gentleman, 67 years old, again type 2 diabetes, hypertensive, previous smoker, and dyslipidemia. A long history of coronary artery disease. The very last one actually that matters was in 2018, unstable angina, and then referred for a new coronary angio. This is what we found. The RCA was good, absolutely patent. There was a patent LCX with a obtuse marginal stenosis. The LAD was patent, but if you look at the intermediate branch on the right side of this slide, you see there is a very tight stenosis, relatively short, in a decent, very decent intermediate branch. So we proceeded with a angioplasty, and then we put an abluminous desplasty by 16 with a very acceptable final results. So the OCT was planned and then performed. We observed no critical stenosis at the angio follow-up, but of course, as I said, this patient has been as well enrolled in the Ability pilot study. So that's the OCT again. Well, differently from the previous patient, this patient didn't notice. We didn't notice a very severe and diffuse disease in this case. And there was not a big progression of the disease, despite the fact that it was diabetic since a long time. But I would like to draw your attention again on the stent. The stent, in particular, at the edges, appears to be absolutely very well performing. In particular, because you see that the struts now is coming. The struts are fully covered. There is no clue, absolutely no signal of particularly aggressive restenosis, absolutely nothing, including the proximal edge. The proximal edge, I have to mention, is very close to a bifurcation, so it's a very weak spot for the coronary bed. Again, some calculations. This is to show the nice endothelization of the struts, and these are some numbers. The MLA we found was 3.97 millimeters square. Max neointimal thickness 0.18. The strut coverage again 100% and 9 months. Neointimal area, the narrowest segment, was 0.68 millimeters square. This was an absolutely fantastic result. This is case number 3. Well, this is a female patient, 60 years old. Again, type 2 diabetes, hypertensive, dyslipidemic, with overweight. So, in other words, this patient has been admitted with a non-STEMI, and as you can see here, there was a really, I would say, really complicated situation. This is the left coronary artery was absolutely okay. There was a critical stenosis in the mid RCA. So this patient, and this is also the vein graft, the rima to the LAD and the lima to obtuse marginal. So they were relatively okay. So this patient has been admitted for the treatment of the RCA, and then we perform with the implantation of Exines Alpine 3x38, post-dilated with NC balloon. And this was the final result, pretty acceptable, we have to say. The planned RCA OCT has been done according to the plan, according to the protocol, and this is the result of the OCT. Even in this case, the stent had very good performance, we have to say, and it was actually one of the reasons why we are comparing this new technology against the everolimus family, because we are absolutely aware about the good performance of this device. So if you really want to test this new technology, you need to test it against one of the best, and that's for sure. These are some numbers. This is the strut coverage, and this is also one of the narrowest segments. These are some calculations. The MLA was 5. The max neointimal thickness was 0.25. The neointimal area at the narrowest segment 0.73, and again, strut coverage 100%. So these are my take-home messages. The preliminary clinical data concerning the Abluminous technology showed promising in both the general and the diabetic population. The preliminary data from the OCT images showed at least comparable results with the Oberomulus-eluting stents family. Indeed, there is a strong rationale to further investigate the potential of this new technology in the field of diabetic coronary artery disease treatment. And I'm pretty sure that Dr. Morice will give us a lot of enthusiasm for these future developments. And I take the occasion to thank you for your attention and for the occasion of talking about this experience.
Luca, thank you for this wonderful presentation, very well illustrated with wonderful imaging. And talking about imaging, I was always a great enthusiastic about OCT and intravascular ultrasound, and how these images can work as surrogates for future clinical trials. So based in your vast experience, Luca, in looking at very careful of all these OCT images with Abluminous, do you think that this can really be translated and have an impact into clinical data?
Well, for sure, we're talking about surrogate markers. So in other words, we need to be careful in every possible evaluation. Nevertheless, we all know, as you nicely shown before, that one of the main, let's say, main limitations of every drug-eluting stent available nowadays in treating diabetic patients is the fact that they are more prone to a lot of restenosis, a lot of tissue growing inside the stent. So we were searching for a signal. In other words, a signal of exaggerated neointimal hyperplasia would be a bad news. We actually found exactly the opposite. So the stent is fully covered, endothelialization was beautiful, and there was no signal at all of exaggerated neointimal hyperplasia. That's the thing we were searching for. So in other words, we are now sure that this device is effective and safe. So we need to further investigate, because of course we need to create robust evidence, and to do that we need clinical data, but starting from robust imaging evidence.
Good news. Thank you so much, Luca. Now we move to our last presentation that will be given by my good friend Marie-Claude Morice. She really designed a very bold and brave trial, again, the largest, as far as I know, to treat diabetic patients with coronary stents. Marie-Claude, the word is yours.
Thank you, Alex. So let's speak about the big trial that we were alluding to, the Ability Diabetes Global Trial. This is my conflict of interest concerning this trial. And yeah, the rationale, we speak about diabetics, but diabetic population is exploding, increasing year by year, and it will continue to increase. So it represents really an unmet need. And our objective is to compare with clinical endpoint, of course, the efficacy and safety of the Abluminus DS sirolimus stent versus the everolimus-eluting stent in diabetic patients eligible for PCI. We think that we will have at least 40% of multivessel disease and 30% with acute coronary syndrome. You saw the design of the stent. We really thought, all of us thought that it was good enough to address this unmet need of the diabetics, because it has the abluminous coating that you saw, the fusion coating that is all over the stent and the balloon, and the biodegradable film that goes everywhere, as we say, and the particular edge coating. We know that there is restenosis at the edge often. So this was the device designed to treat the diabetic patient. So our hypothesis was that providing more homogeneous, more drug and greater drug delivery per square millimeter at vessel wall, we will result in a reduction of restenosis at 1 year follow-up in diabetic patients. This is the design of the trial. As said, diabetic patients eligible for PCI, they will be followed from 30 days to 2 years. It's prospective, multi-center, multinational, and randomized 1-to-1 open label. It's blinded just after the implantation. Endpoint is ID-TLR at 1 year, and it's powered for non-inferiority and sequential superiority. And if non-inferiority is met, and the TLF is powered for non-inferiority. We aim to work in 20 countries, 100 sites, Europe, Asia, Australia, Latin America, 3,000 patients, largest trial head-to-head. And of course, it's the abluminus that we say against the Xience. So the flow is the following. We screen diabetics eligible to PCI. They have, we screen if they have inclusion-exclusion criteria that we'll see later, very few. They need angiographic exclusion criteria. They have the angiogram. And if they don't meet the angiographic criteria, they are a screening failure and we follow them. But if they met, randomized to abluminus or Xience. And we take all the diabetic patients, and it's all comer. All the diabetic patients that will enter the site are potentially for the trial. They can be or documented diabetes or newly diagnosed, and they can be type 1 or 2, treated with pharma meds only or by insulin, all diabetic patients. And they need only to be symptomatic or chronic stable angina, silent ischemia, and non-STEMI acute coronary syndrome. the angiographic, it's very large. They can have at least one lesion, but there is no limitation in the number of treated lesions, number of vessels treated, or lesion length. We want to treat all the diabetic patients, of course, that are amenable for PCR. You see only 3 exclusion criteria: cardiogenic shock, STEMI for problem of consent, and severe renal dysfunction. And our primary endpoint, as I told you, is ischemia-driven TLR at 1 year, powered for non-inferiority and sequentially superiority. And the TLF, target lesion failure, that you see there, powered for non-inferiority. And we have, of course, many secondary endpoints, but we have the cardiac death, target vessel myocardial infarction. Of course, we look to the 2 years follow-up. We look to the many composites. We look to the bleedings, BARC2 and greater, and technical success, stent thrombosis, mortality up to 2 years, target vessel revascularization up to 2 years. How the study is managed. It's sponsored by Concept Medical, and we are extremely all grateful that Concept took the courage to run this trial that was really needed. And it's organized between 2 organizations, Mount Sinai, with in charge of project management, CEC, data management, and statistical analysis, and CERC. We do regulatory, project management, contract monitoring, SAE reporting, and the core lab. And this is the executive management. You see that there is a nice executive operation committee, Roxana Meran being the chairman of the committee, and we have 3 PI, Antonio Colombo, Alexandre Abizaid, which is with us today, Shigeru Saito. And the steering committee is the same people, plus Fadzila Malik, David Hildismith, Darius Dudek, Dr. Toll, and Benjamin Faury. So you see very serious person taking care of a very serious trial. And so the trial is not double blind because the devices are different, but we blind immediately after the procedure, meaning that in the report, it's written study stent, and nobody that is doing the follow-up knows which stent was implanted. This is the study status. In green, you see where we have the approval. In orange or yellow, where the submission are already done, and in red, where we have to submit. But yeah, trial is really on its way. Yeah? So, my friends, dear ladies, dear gentlemen, to conclude on this trial design, I must say that diabetic population is increasing worldwide and continue to have a poor outcome despite all medical improvement and years of medical improvement. And the Abluminous device represents the combination of a drug-eluting stent and a drug-eluting balloon with the advantages of both systems. And it has the potential to address better this particular population. And this trial, the Abluminous Diabetes Global, is the largest head-to-head stent trial for diabetic patients conducted so far. Patients will be recruited in all continents, allowing the conclusion of the trial to be applicable worldwide. I want to thank you all for your attention.
Thank you so much, Marie-Claude. I think this was superb. We are looking forward in perhaps less than 2 years to have the response and then the results of this trial. I think it's going to be fascinating for us to have one more tool in our cath lab to treat diabetic patients. I believe that Luca has a question, and then we can conclude.
Yes, I have a question. I mean, I would like to link to the very last sentence of your presentation. What's the real meaning of having a worldwide study? I mean, we all know that there are ethnicities, countries with different percentages of incidence of diabetes, but how can you really make sure that what we are doing is applicable worldwide? What's the real meaning of it?
It's let's say it's a combination of two things. First, you have a lot of patients, 3,000. And second, we recruit everywhere. And as you say, according to country, the rate of diabetes and type of diabetes and even genetic of diabetes is different. So we will have patients coming from all over the world, and also it will allow to do by subgroup, by type of diabetes, by continent. As Asian patients are not reacting the same to treatment than us. So yeah, the applicability will be worldwide because we are recruiting patients everywhere, and we are recruiting a lot of patients everywhere.
That's right.
So I have a question for both of you. Seeing very carefully and looking at the stent design and all the important features of Abiluminous in terms of release kinetics and the fact that you have more drug distributed to the vessel wall and to the edges, my question is about bifurcation. I think that with Ability study, we're going to see many patients with diabetes that we're going to be treating with the stents. And again, Luca can give some insights from imaging, particularly for provisional. When you use a provisional technique for bifurcation, do you think that there is any potential advantage of the fact that the balloon is also coating to perhaps spread some drug to the ostium of the side branch? Is this pure speculation or there is any meaningful, perhaps mechanistic explanation why perhaps in the future we're going to use this stent for bifurcation? Let's start with Luca.
Well, I would say that, of course, we don't have a properly sized trial to evaluate this. Nevertheless, I mean, I can actually give some information according to my experience, and have to say that we all know that for a bifurcation, the weak spot is the ostium of the side branch. That's for sure. So we all know that if we can actually provide more drug right in that specific place, we might be potentially be able to address the issue of restenosis in the bifurcation. And I have to say, following this patient with the OCT, I didn't notice any impairment of side branches because, of course, we treated some bifurcations, that's for sure. So this is just coming from the evidence. I cannot prove, as a matter of fact, that with this is something true. But coming from my experience, I have to say that probably there is some kind of advantage in this abluminal coating on the balloon and on the stent. So this technology merging the features of a DCP and the feature of an abluminal coated DES may be a potential solution for this issue. But again, cannot prove it, but potentially is absolutely reasonable.
So Marie-Claude, for Ability DM trial, are we going to allow any drug-eluting balloon to the side branch when you have a bifurcation? I think it's perhaps too many questions in one, right?
No. Honestly, I don't think that you can mix DEB and a drug-eluting balloon in kissing. Let's say we'll have to check. And I know that imagination of investigator is endless. We say all comers, so you will see. We will see probably that. And it's not an exclusion criteria. Bifurcation are not excluded for sure. We really want the real population that we see in real life, the all-comer diabetes. Of course, that are not indicated to surgery, but yeah, we want them all, yeah.
Yeah, but in the future, we're going to have to ask this question, whether, you know, Abiluminous for the main branch and a magic touch for the side branch. Perhaps this combination will be excellent for bifurcation. And in the same lines, Marie-Claude, for ACS patients, that's another subset of patients that I'm very interested, because, you know, those patients will have more thrombotic lesions, will be perhaps a sicker and more complex lesions by itself, right? So do you think that perhaps the combination of a balloon coating with a strut coating will be particularly interesting for ACS patients?
yes, it should stabilize even better the plaque that when we are doing what we are doing with only a stent. That's for sure. It's the distribution is really, the plaque will be really well covered, which is because with this thin layer. So it has the potential, yes, to improve the outcome there. And to insist on what you were saying about the bifurcation, but it's in general, it's a DES plus drug-eluting balloon. So we need to inflate a little longer. That it's not expanded as a DES. You need to leave the drug-eluting balloon time to put the drug on the wall. I think it's something very important. It's an unusual procedure. 45 seconds of inflation minimum. Yeah.
And Luca, I was particularly interested on your work on the analysis at the edge of the stent. I think that's also a problem, particularly with diabetes. I think we see a little bit more edge restenosis in the diabetic population versus non-diabetic. So tell us a little bit about that, and if it's going to play an important role for your decision in the future.
I think this is really a key point. I mean, we sometimes forget about this, but all the available drug-eluting stents on the market, they are not eluting any drug at the edges. Yeah. And the distance from the polymer to the real edge of the stent is very variable according to the manufacturer, different type of stent. Anyway, no one really remembers that the drug-eluting stent is no longer a drug-eluting stent at the edge. Yeah. So the edge coating is something really crucial in order to minimize the risk of edge restenosis. And the two cases that I've been showing are actually meant to show that this coating at the edges may be the answer for the most typical restenosis in diabetic patients at the edges. Yeah. Of course, we need to conclude the enrollment, we need to conclude the follow-up. Nevertheless, what we have seen is a proof of concept. So it works. On a large scale, question mark, but it works.
So that's an important statement, because I think that Marie-Claude will have another study to design in the future, because if there is a good sign that abiluminous will be a great solution for diabetes, and perhaps even a little bit better than Zions or what we have current in our shelves, she will design another study with diabetes against surgery, because then I think it's going to be very competitive, right? Because it's going to be the only default therapy that we're going to have to go against in the future.
Absolutely, I completely agree with you. If we look to the valve story, look with TAVI, we go high risk, intermediate risk, low risk. Now there is no room for surgery. In PCI, we maybe will do the same, because the diabetic patient is the last remaining situation where the patients are doing better with surgery than with PCI.
So wonderful. First, I would like to thank Luca, Testa, and Marie-Claude for the wonderful presentation. I think this is a very meaningful subject for us to discuss. I have to conclude to saying that diabetes is still a problem. I don't think we have a perfect solution. It's generally with a lot of diffuse disease and less favorable results. I think that we can also agree that the current DES technology did not resolve all the issues. We still have open questions and not perfect long-term results. So I think that to give credit to smart engineers that can help us and come up with customized DES, such as abiluminous, to provide us with another tool to treat these very complex patients with not favorable results. I think that's something that we welcome and we appreciate. Finally, thanking Concept Medical for allowing us to discuss and to have one more tool to treat diabetic patients. And very soon, we're going to have a very strong body of evidence to put this stent in a different platform. Thank you so much, everybody, for your attention.